an asymptomatic 65-year-old male undergoes a routine pre-employment screening. I am showing you his frontal chest radiograph and a zoomed view of the mid-lung zone and hilum. Describe the findings.
The frontal chest radiograph and corresponding close-up view demonstrate a small, well-circumscribed, densely calcified subpleural nodule in the mid-lung zone. Additionally, there are multiple calcified lymph nodes within the ipsilateral hilum and the urticopulmonary window. There are no active airspace consolidations, pleural effusions, or cavitary lesions.
State your primary diagnosis and the clinical terminology used to describe these combined findings.
The diagnosis is a Ranke Complex, which indicates prior healed primary tuberculosis. The calcified subpleural parenchymal nodule is a Ghon lesion or focus, and its association with calcified regional ipsilateral hilar or mediastinal lymph nodes forms the Ranke Complex.
Are these findings more closely associated with primary or reactivation tuberculosis?
A Ranke Complex is characteristically associated with healed primary tuberculosis, representing the regression and calcification of the initial parenchymal site of infection and draining lymphatic involvement.
Explain the clinical distinction between a Ghon focus and a Ghon lesion.
A Ghon focus is the initial area of acute parenchymal consolidation caused by primary tuberculosis inoculation. A Ghon lesion refers to the subsequent well-circumscribed, solitary calcified granuloma that remains after the acute consolidation has regressed.
What are the two most common radiographic findings associated with acute primary tuberculosis in symptomatic patients?
The two most common radiographic findings of acute primary tuberculosis are parenchymal consolidation, which typically involves the middle or lower lung zones, and mediastinal and hilar lymph node enlargement, often showing low attenuation necrotic centers on computed tomography.
How does the radiographic presentation of primary tuberculosis differ from post-primary or reactivation tuberculosis in adults?
Primary tuberculosis typically presents with middle or lower lobe consolidation, lymphadenopathy, and occasionally pleural effusions in unexposed hosts. Reactivation tuberculosis characteristically affects the apical and posterior segments of the upper lobes, showing cavitation and bronchogenic spread with a tree and bud pattern, and lymphadenopathy is typically absent in immunocompetent adults.
Describe the histopathological findings of a healed tuberculosis granuloma.
Histopathologically, a healed tuberculosis granuloma demonstrates central caseous necrosis, surrounded by epithelioid histiocytes, Langhans giant cells, and a peripheral lymphocytic cuff, which eventually undergoes dystrophic calcification and fibrous encapsulation.
Explain why the identification of a Ranke complex is clinically critical before initiating biological therapy.
An incidental Ranke complex represents latent tuberculosis. If a patient is scheduled to receive tumor necrosis factor alpha inhibitors, such as infliximab or adalimumab, there is a high risk of reactivation due to disruption of the granuloma structure, which can lead to life-threatening miliary or disseminated tuberculosis.
Detail the mandatory screening and prophylactic steps required before starting such biological agents.
Before starting biological therapy, screening for latent tuberculosis with an interferon gamma release assay or tuberculin skin test is mandatory. If positive, a full course of latent tuberculosis prophylaxis, typically with daily isoniazid for 6 to 9 months, must be initiated to prevent reactivation.
State the critical safety warnings associated with this case and outline your recommendations.
The critical safety warnings are reactivation of latent tuberculosis leading to disseminated disease under immunosuppression, and misdiagnosing an active atypical infection. Radiologists must immediately recommend latent tuberculosis screening with an interferon gamma release assay if biological therapy is planned, suggest sputum AFB smears and PCR if active symptoms develop, and advise prophylaxis initiation. Refer to infectious diseases and pulmonary medicine